Hello, and welcome to our presentation on community-acquired pneumonia. My name is Sarah, and I am one of the pharmacy residents here, and today Tiffany and I will be guiding you through the guideline update. So our objectives for today are going to be to recall the common pathogens causing community-acquired pneumonia, to be able to recognize the risk factors for MRSA and Pseudomonas, to be able to summarize the updates to the 2019 CAP guidelines, and to be able to implement the guidelines to hopefully treat our patients. So looking at an overview of CAP, the guidelines were recently updated in October. They are put out by the American Thoracic Society and the IDSA. This guideline was recommendations that were based on 16 important clinical questions, focusing on adults in the United States, and it's really important to note that immunocompromised patients are not included in this guideline. And basically, they got rid of the HCAP, and they're just differentiating between CAP and severe CAP. So, how do you determine if the patient has severe CAP? It's going to be either one of the major criteria, so if they need vasopressors or if they are requiring mechanical ventilation, or if they have 3 or more of the minor criteria. And you can see the minor criteria is just various labs that you can look at to see how sick the patient is. So with our more common pathogens, we are going to want to empirically cover for all of these. So for any streps, H. flu, mycoplasma, Staph aureus, Legionella, chlamydia, moraxella, and then there is also increasing emergence of viral pathogens. So moving into the diagnosis. Per the guidelines, there are recommendations on both getting a sputum culture and or blood cultures is that really it's only necessary if the patient has severe CAP or they either have risk factors for MRSA or Pseudomonas, or they've been empirically treated for MRSA and Pseudomonas in the past, or if they have received any IV antibiotics within the last 90 days. If the patient is just a normal CAP patient, getting sputum cultures and blood cultures is not necessarily recommended. Blood cultures in community-acquired pneumonia rarely actually produce any organism, and the sputum cultures are also not very accurate due to the low yield of bacteria. In regards to the urinary antigen testing, we can either test for Legionella or pneumococcal, and in general, the guidelines are not recommending using these tests, and only except if the patient has severe CAP or if it is indicated based on epidemiological factors, so either a Legionella outbreak or if the patient has any recent travel. The guidelines really doesn't specify what specific travel they're talking about. So in regards to when to test for influenza, it's recommended to test during high activity of influenza, and you can consider it if there's low activity of influenza. And then they recommend the rapid influenza molecular test over the other one, which we do use the molecular assay here. So what about procalcitonin? This topic was actually, I think, brought to our attention because of the procalcitonin. It appears that we use this a lot. So the guidelines actually do not recommend using this if you are clinically suspecting that the patient has community-acquired pneumonia and it is radiographically confirmed. This shouldn't delay the initiation of antibiotics. You should just put them on the CAP treatment and call it a day. The recommendations for this are based off of multiple studies that the guidelines looked at. They had anywhere from a sensitivity, so the incidence of detecting true positives, from 38% to 91%, which is a very huge range of variability. So it's not maybe as accurate as we thought, and then also the level at which we should kind of be saying this is a level that you should look at for bacteria versus viral is not really standard across all the studies, so really probably not recommended, except in situations where the patient maybe has a CHF exacerbation where we're not sure there might be an infectious process to maybe use it to rule out bacterial infection. If the patient has COPD exacerbation, we could probably use it to rule out a bacterial infection. And then also in the cases of viral infections, you could also use it to see if there is an underlying bacterial infection. So determining if the patient needs to be outpatient versus inpatient, the guideline discusses these two scoring systems. So the pneumonia severity index, which is the preferred, according to the guidelines, just due to the higher discriminative power of predicting mortality, and then the CURB 65, which there's just less evidence to recommend it. So here is an example of the CURB 65 score, so you can see where they get the different points from and kind of which, you have to have 3 or more points to kind of for sure get you an inpatient admission. And then, so for the PSI, you can see that this looks at a lot of different additional factors in addition to the CURB 65, just to make it kind of more specific for the patient, and you can see how it would have a higher predictability for mortality. And then how do we decide if our patient should go to the general floor versus the ICU? We're going to use the minor and major criteria to kind of determine that. So if they have severe CAP versus non-severe CAP. So if they meet those major criteria, vasopressor or mechanical ventilation, probably should go to the ICU. And other people that do not meet those 2 major criteria, really they're just recommending clinical judgment and the use of the minor severity criteria to determine if the patient needs the ICU or not.
Okay, so moving on to the treatment of CAP. Treatment for patients without risk factors for MRSA or Pseudomonas. So we'll be talking about what those risk factors are later, but we'll just talk about if they don't have those risk factors, how do we treat them now? So you need to use a beta-lactam plus a macrolide. The macrolide will cover the atypical pathogens associated with CAP. Or you can use fluoroquinolone monotherapy because that covers atypicals as well. For beta-lactams, I have the options listed here in the recommended doses. Here are the macrolides, azithromycin or clarithromycin. If a patient has a macrolide allergy, we can use doxycycline and we'll get our atypical coverage there. Here are fluoroquinolones. We, of course, have to use the respiratory fluoroquinolones because those are the ones that will cover the pathogens. For the beta-lactams, we prefer to use ceftriaxone because that's dosed once daily. Additionally, it has no renal dose adjustments. And we like to use azithromycin also because that is dosed daily, whereas clarithromycin is dosed twice daily. For azithromycin, we just need to get to 1,500 milligrams before we can stop treatment. For fluoroquinolones, we should avoid them if we can due to the vast amount of side effects they have. They're the antibiotic that causes the most C. diff and other various side effects. Drug-drug interactions, for example, with warfarin and resistance. If we have a suspected aspiration pneumonia, do we need anaerobic coverage? Likely, no, we don't, unless the patient has a lung abscess, which for most abscesses we usually do cover anaerobic pathogens, or if the patient has empyema, which is really just a different disease state. Patients who aspirate gastric contents have aspiration pneumonitis, not pneumonia, and many of these patients have resolution of symptoms within 24 to 48 hours with only supportive care, so without any antibiotics. So what do we use when we send our patients home with CAP? So this can be both in the ED if we just want to give them something to take at home, or if they're inpatient and we're transitioning them to outpatient. For our healthy patients with no comorbidities or risk factors for resistant pathogens, we can use amoxicillin. The 1 gram TID is a really big dose, so we might have a risk for diarrhea, but that's just what the guidelines say. It does have azithromycin or clarithromycin as monotherapy options if the pneumococcal resistance to macrolides is less than 25% in the area. However, there really aren't any places in the US that have resistance that's less than 25%. So pretty much if you're prescribing in the USA, you should not use macrolide monotherapy. If patients have a chronic comorbidity such as heart, lung, liver, renal disease, diabetes, alcoholism, malignancy, or asplenia, then we're going to have augmentin instead of just the amoxicillin by itself. And in this case, macrolide monotherapy is not an option. So we can choose either of these options. Again, if the patient has a macrolide allergy, we can use doxycycline. Fluoroquinolone monotherapy is an option, but again, with all the side effects and risk of resistance, we should try to avoid this if we can. Here are the options. These are the respiratory fluoroquinolones. For risk factors for MRSA and Pseudomonas, so when we need to consider broad antibiotics, in the past 90 days, if they've been hospitalized, had exposure to parental antibiotics, or if we've had prior isolation of either MRSA or Pseudomonas. If a patient does have these risk factors for MRSA or Pseudomonas, we're going to maintain empiric broad spectrum coverage, obtain an MRSA swab and sputum culture, and then we can go ahead and de-escalate from broad antibiotics if we don't yield either of these pathogens within 48 hours. For empiric coverage of these pathogens for Pseudomonas, the most common ones that we use are Zosyn or Cefepime. At our specific institution, our antivirogram shows that Cefepime has actually better coverage of Pseudomonas, so we typically would prefer to use Cefepime. Additionally, it's a little more narrow than Zosyn. Also, some physicians worry that Zosyn paired with vancomycin can increase your risk for nephrotoxicity, so it might be better to avoid Zosyn use and just use Cefepime if you are worried about that. For MRSA coverage, we can use our vancomycin, and you can just use pharmacy to dose or linezolid. One of the biggest things about this guideline is that there is no more healthcare-associated pneumonia. So we will no longer use these risk factors of being in a healthcare system to guide empiric therapy. Studies have shown that the criteria to identify HCAP patients does not predict the prevalence of antibiotic-resistant organisms. So someone just being in a nursing home is no longer a risk factor in and of itself to justify using broad empiric antibiotics. Should we use corticosteroids for CAP? If it's severe, and even if it's not severe, corticosteroids are not recommended for routine use. If a patient's in septic shock, then you would go ahead and transition to the sepsis guidelines to guide you on whether or not you should use them. So if they're septic, don't use these guidelines, switch to the sepsis guidelines. For patients who test positive for influenza, the guidelines recommend starting anti-influenza treatments like Tamiflu, regardless of duration of illness before the diagnosis. While it is true that it's best to start treatment within 2 days of symptom onset, benefits are seen up to 5 days after symptom onset. So if they have the flu, you can also start antibiotics, as bacterial pneumonia can occur at the same time as the flu. S. aureus is one of the most common bacterial infections that's associated with the flu. However, we would still treat it as CAP MSSA. So we have a greater risk factor of having Staph aureus, but not MRSA. So you would still treat it with CAP, and that would go ahead and cover your MSSA. The duration of treatment for CAP is 5 days, at least 5 days. But we need to just look at how the patient is clinically improving. Are they able to eat? Are they breathing normally? If no clinical improvement is seen in 5 days, we need to consider that we're missing something. Resistance, Did they have a complication for the pneumonia? Do they develop an abscess or empyema? Is it an inflammatory process, or are we missing an alternate source? So 5 days, consider if they're clinically improving. If a patient is improving, should follow-up chest imaging be obtained? If the symptoms are resolving within 5 to 7 days, it's not recommended. That is all we have. Thank you so much for listening.